between the policymaker of Ministry of Public Health and patient groups or other key players who involved in ART and RRT. Later on, antiretroviral therapy is included since 2003. This is because of the political decision, pressure by international NGO, and the capacity of Thailand to produce the low cost of ARV. For the renal replacement therapy, it took longer time. It was included in 2007. Once we found out that renal replacement therapy interventions, both peritoneal dialysis, hemodialysis, and kidney transplant were not cost-effective. But with the other consideration of the policymaker, they decided to include it in order to prevent catastrophe of the household. That was the informal process. For the formal process of priority setting within the UC scheme, it just started in 2009. We say that it is participatory, transparency, evidence-based, and contestable process. We begin with the topic submission. 7 groups of people who are policymakers, academia, professional, patient groups, civil society organization, industrial group, and general population can submit topics that they would like to propose for consideration. Each group can propose up to 3 interventions, not more than 3. We allow the process twice a year, during January and June every year. These 7 groups will propose the topic, and then we come up with 21 topics. We don't have capacity to do assessment for all 21 topics in detail. Therefore, we have a process of working groups to consult together and come up with topic selection with the 5 criteria: magnitude and severity, effectiveness of intervention, variation in practice among the 3 schemes of Thailand, financial impact, equity dimension, and other ethical dimension. For example, 21 topics might be selected as only 10 topics because of limitation of research capacity. IHPP and HITAP cannot do assessment more than 10 topics during the 6 months. It's too many. We try to reduce to 5 or not more than 8 per 6 months, because we need to run throughout the year. When the topic was selected, it comes to the researcher in the middle of the PowerPoint. Researcher from IHPP and HITAP did an assessment of each topic on its cost effectiveness, budget impact, equity dimension, as well as supply side readiness. When we the full-blown assessment, we propose to the subcommittee on benefit package of the UC scheme. This is subcommittee will do the appraisal. Sometimes they request the researcher to fine-tune more on solution or whatever they think it is important for policy decision. After pass the appraisal of the subcommittee, the subcommittee will propose those policy options to the decision of the UC scheme by the board. We have 30 members of the board of the UC scheme, chaired by the health minister. Among 30 members of the board, we had 5 seats from NGO to sit in the board. I will show you in more detail in here. The board will make decision whether or not that intervention will be included in the UC scheme or not. Stakeholders can appeal if they need it. This is an example. For example, in the yellow line, medicine for chronic hepatitis B and severe lupus nephritis. Very easy. They are cost effectiveness, low impact on budget, and then the decision is yes, included in the UC scheme. Come to the purple line, the purple color, impact dangers. Yes, it is very cost effective, very low budget impact, but the board decided not to include it into the UC scheme because of the problem in delivery as well as equity concern. Most of the dentists who can do it are concentrated in the urban setting, and at this moment the simple dangers cannot be delivered to elderly patients, and then the board decided not to include it even though it is cost effectiveness. For the green color, for the medicine for chronic hepatitis C and adult diapers for the urinary and fecal incontinence. They are very cost effective, but very high impact on the budget in the future. The board decided not to include it in the UC scheme. Another reason of adult diaper is that it can be used by the local innovation. For example, they use a fabric to use instead of the diaper. That is costly. Another example on severe asthma for the new medicine. It is not cost effectiveness and then very high budget impact. The decision is no, not included. We use the ICER ratio of 1 GDP per capita per quality gain. That is in detail in the technical detail. This is just example on health assessment as well as other assessment evidence and put into the policy decision, which is not always based on the HTA alone. Then you can see that people participation. I think this is the previous one. Anyway, people can have voice in the UC scheme in many channels. You see already benefit package, and then I will show you more in other aspects. As well as people can have their voice beyond the UC scheme, which is National Health Assembly. For the UC scheme, as I mentioned you, the people can be sit in the board of the UC scheme. There are 5 seats for the NGO, 4 seats for the local government representative. This is the data of the 9 NGO groups that it is in the law. Among themselves, they need to select 5 representatives to be sit in the board of the National Health Security Office as well as Standard and Quality Control Board. Another aspect is public hearing of the UC scheme. By law, it is already indicated that public hearing must be conducted annually. The various topics of benefit package, quality of services, etc. From whom? From various stakeholders, including provider, beneficiary, public health officer, as well as local government officer. Around 10,000 participants per year. They did at the national level and then expand to the district level, provincial level, and then they wish to expand to the sub-district and district level later. Another way of information is on satisfaction survey. It is an annual conduct by a private university in Thailand. We conduct both consumer and provider satisfaction, which can show you. It is very simple to see that the provider had lower satisfaction score by the consumer. This is common. Another way of getting voice from people is from the call center customer service 24 hours, 7 days. We get a call from many people, either general population or provider or any people who would like to call. You can see that the number of calls is around less than 1% of the total OP visit. The majority of the call is for information and Q&A. Only few complaints and further and very few for the request for further decision and solution by the board. Another thing that I would like to say here is National Health Act in 2007 mandate the National Health Commission Office to conduct the annual National Health Assembly. This is another way for public participation. Normally, we had the approach of hard power from the politician to the technocrat to the Ministry of Health and go to the implementation, and people are the beneficiary of the public services. However, the National Health Assembly is another way around. It gets from the people participation to the National Health Assembly, and then it can go up to the cabinet as a resolution. We conduct every year around December, the end of the year. Various organizations involved in the National Health Assembly. This is examples of 72 resolutions of 9 National Health Assemblies. It involves in both health system, universal health coverage, or other social determinants of health. Then you can see that people can participate in UC scheme and beyond the UC scheme. One example from the civil servant scheme, from the people participation, which come out not a good outcome. We know already that civil servant scheme has a very high cost escalation due to the fee-for service. We found out that they use the non-essential drug for treatment of osteoarthritis. These medicines are ineffective. Glucosamine, one among the 4 medicines, took around 45% of the total expense. Then we proposed that glucosamine in the negative list. However, there are many opponents on the case. Many interested groups, for example, surgeon, orthopedic, pensioner who get the benefit, make loud voice against the negative list to the mass media and put the pressure to the government. Finally, what happened? Only half year or less than half a year, glucosamine came back and could be reimbursed from the civil servant scheme anyway. This decision was a result of the political pressure. This is my last slide. Stakeholders who are part of problems are also part of solution. It needs to bring them together on board. In a deliberative process based on evidence, but not always that we can be successful. You can see some success and non-success process in Thailand. Increased capacity of the civil society is also important. Active citizen is a key factor. Another lesson from Thailand is that the national capacity is very important, is very critical to build up the evidence, as well as platform to link those evidence into the policy process. Will be very good platform for matching or linking the evidence into the policy process. Otherwise, evidence will be on the shelf. Thank you very much.
Thank you very much, Wolapon. I think one never tires to hear of the Thai case, so extremely well developed in terms of the processes and so on by any standards. So we have Chris Hatim, I think, on the line, but again, I'm just going to open up if there's any questions or clarifications. I'm sure we could talk for hours about the Thai case, but if I see any hands, I'm happy to take them now. Yeah, okay. Well, go ahead, Joe. We have. Okay.
Thanks, Joe Cutson from the WHO Health Financing team. Just one of the slides that you showed is something that I think is an important one too. Well, many are important, but one that I try to rely on in other settings as well had to do with the composition of the board of the National Health Security Office, and it's an important reminder to keep in mind the objectives of what we're trying to achieve with these things, right? Because the idea is to reflect the beneficiaries and to reflect the various stakeholders. And it's a real departure from the traditional way that governance has been established under, let's say, traditional social health insurance, which is this term of tripartite governance of government, labor, and employers. And that is an inheritance from Europe, basically, from European social health insurance systems in the context of where most of the population is actually in the formal workforce. And your example highlights that that's not the world of most countries. And it doesn't make sense to have a governance arrangement that leaves out 80 to 90% of the population in that sense. And to have this broader governance is really more important. And so it's just another I guess, reminder that if we're thinking about universal coverage as a system-wide context and not just a scheme for workers, then it's really important that the governance arrangements reflect that, as in Thailand. So thank you for that.
Okay. I don't see any more hands, so I think we'll keep going, and we're sort of moving into the third part of the session, third and last part of the session, where all these parts are clearly, closely connected, but a little bit more of a focus on the politics of getting benefits into policy. And I think we have Chris Hatim on the line. Chris, can you hear us?
Yes, I can hear you. Can you hear me?
That's great. That actually works. Wonderful. Chris, I'm going to move the slides for you. Just putting the slides up on the screen, so if you give us 1 minute. So I think probably most people in the room know Dr. Chris Hatim. Chris is a health system specialist, focusing particularly on health financing. He's currently Senior Program Director at R4D, Results for Development, advising on USAID's global flagship maternal and child survival program. He's based in Ghana currently, where he's dialing in from. And Chris is also I could go on for a long time, but he's also Executive Director of AFHERE. I think most of you know that. So your presentation is just coming up now, Chris.
Yes. Hello.
Okay. So we have the slides up now. So please go ahead and just tell me when you want the slides moving forward.
Okay. Thank you, and good morning to everybody. Sorry that I can't be there with you in person, but I'm told that. Although I'm 2 hours behind in Geneva, I've actually leapfrogged all of you in terms of technology. At the forefront of the WHO's new attempt to examine how to hold international workshops from remote locations. So I'm a guinea pig in that respect. Thanks, all of you. I just wanted to share with you the experience that we have in Ghana about reviewing the benefits package. And then, in that process, discovering wider implications for the health system, which were necessary as part of any reform to make the national insurance scheme work better. Now, most of you know that. So, next slide. Most of you know that the outline. The Ghanaian insurance scheme. I think I'll talk basically about 3 main things. Here in terms of the review, the background to the review, the process that we use, and some main findings and recommendations that emerge from there because of the time limitation. So in terms of the background, most people know that Ghana had a health insurance scheme set up by law in 2003, came covering about 40% of the population now, It's basically tax funded with very little contribution from other sources like premiums. Now, by 2009, there were some challenges that were becoming very apparent. The first one was, and perhaps the most difficult one, was the technical deficits of the NHIS, of the National Insurance, which were becoming a problem, and were expressed especially in the delayed payments to providers, which put the sustainability of the whole scheme into question. There was also, again, emerging from that, an effective return of the user fee system, where providers, because they were not being paid on time, are actually charging users directly for services that should be insured and should not have any fee or even co-payment on them. And there was a growing sense in some circles that as a result of all of that, the benefits package was too generous. Ghana, the benefit package is well known to be pretty generous. I don't know about too generous, but certainly very generous. And the total said to cover about 95% of the conditions, the health conditions of the population. So that's pretty expensive. But there were people beginning to actually argue that the benefit package was rather too generous and that was not affordable. There was certainly rising user and provider dissatisfaction also with the scheme. And I mean, in a broader context, here too was that the health indicators, some of them like maternal health, were not seeing any dramatic improvement. If anything at all, there has been some recent discussion about the worsening neonatal, for instance, indicator. Just as one example, there were issues about exactly what we're getting as a result of the spending that we're making in the health sector. So all of these issues were there in the background. As a result, the president set up a review committee 2015 with a mandate to review and make recommendations on the sustainability, efficiency, equity, and accountability and user satisfaction or responsiveness of the scheme. There was a particular specific item in the terms of reference that asked the scheme, the review committee, to examine whether the benefits package could be better aligned with the broad health sector goals of the country. And in that process, they should redesign and restructure the scheme. So that was the context. Now, the process itself it took over a period of 1 year and involved different elements. There were, to begin with, the cost effectiveness of the interventions were not actually questioned as such, but there was fortunately a parallel disease, burden of disease study taking place with very convenient timelines led by the Ministry of Health, the Institute for Health Metrics and Evaluation, and DFID. That work fed directly into our review. So we actually accepted the findings of that work in terms of defining what the priorities were. There was also, we also questioned international evidence around the way we made use of the evidence in the global disease. There were other evidence, that we also used in systematic reviews around benefit packages and so on, the priorities in our scheme. So we actually made use of that, but we also did some technical work as part of this review. We had some desk reviews with consultants who actually reviewed different reports. There have been so many reports and theses and research work on the National Health Insurance Scheme. We reviewed them to find useful information. The principle that there was no need to reinvent the wheel. We also carried out specific surveys where we identified gaps in knowledge that were not answered by any of the sources that we were talking about, but also specific questions that were related to the scheme, such as, for instance, the delays in the payment. I mean, there were many theories about why the delays were happening. Many people said it was the Ministry of Finance that was not releasing the funds in time. So we actually traced, we had a research project that traced the chain of payment from the collection of the revenue from the taxes up to the actual payment to the providers in order to find out exactly where the delays were. And each step in the chain was given some timeline, and this was done by a USA project. We found out that, in fact, it wasn't really true that most of the delays were due to the Ministry of Finance. There were other elements as well. So it was an eye-opener in terms of not taking received wisdom or anecdotes and allegations and so forth as evidence. And then also we had 7 technical subcommittees, which actually studied particular areas such as the benefit package, where the benefit package subcommittee, we had a subcommittee on governance, one on monitoring and evaluation, IT, areas like that. So we had these technical subcommittees made up of the country's best experts, which we could identify, those whom we could identify who were available and willing to support the process, including countries' experts abroad. And the development partners also were invited to send their own experts to participate in those committees. So we had these 7 subcommittees that did extensive, detailed technical work to inform the committee's work. And then the main committee itself engaged mostly in the more political aspect of the process, which is building consensus and finding out the views of the population, and especially the key stakeholders. So we met with providers, users, and the staff of the National Health Insurance Scheme, the purchasing agency, through key informant interviews, through specific meetings with the stakeholders, going to their head offices to meet with their staff and their leaders in their own conference rooms. The key, especially in the health sector, or the key identifiable groups, we try to meet them, to listen to them. We also published calls for submissions in the media, so that anybody in the population that wanted to also submit evidence to the committee on their views on the way the health insurance scheme should be restructured or redesigned or made to work better, could approach us. They actually, some people made use of that. We also had a public fora in some regions, in the key regions of the country, the main ecological zones of the country. In addition, we also went to some districts to visit and to listen to both providers and users in each of those areas, not to engage with them to understand their concerns. So this was a deliberate political process to try and understand their public opinion on the different issues facing the scheme, especially in accordance with our terms of reference, the sustainability, efficiency, equity, accountability, and user satisfaction dimensions of the scheme. Voluminous information, and naturally lots and lots of the documentation that we have actually produced as part of this process. So that was the actual review. Yeah. So the next slide. We then met and went through these finding these various evidence, and actually had the use of, again, consultants to help us to go through to actually distill the main lessons coming out of them. And we realized that, in fact, a lot of the even through the stakeholder engagements, we already discovered that it was not possible to look at the assignment in terms only through the lens of the National Health Insurance Scheme problems. You have to have a wider sector viewpoint, look at the issues affecting the sector as a whole, especially the health financing of the entire sector, rather than simply the problems affecting NHIS. Because the sector issues were extremely important. You have not just the context, many of them actually had the direct impact on the ability of the scheme to achieve the various objectives that were set for it. So we had 2 broad streams of findings and recommendations. Those concerning the NHIS design and operations themselves, the governance, so strengthening governance, efficiency, and accountability. For instance, findings and recommendations regarding mechanisms for citizen voice, how to better report on performance. We actually found that even though the NHIS, and if anybody goes to their website, you'll find that they do publish reports, even though with a lag. They publish some annual reports, sometimes with a considerable lag in time. And the reports look voluminous. They don't provide very much information, actually, for somebody to understand its operations and its performance, its efficiency, and so on. So we actually we looked at evidence of best practice, for instance, in Estonia, which I produced some evidence, some examples of the kinds of reports that are produced by good performance schemes or schemes that try to show accountability and transparency in their operations in order to show what could be done to improve the performance of the NHIS. Also, findings around the provider relationships, you know, especially because of the tensions between the providers and the purchasing agency. You know, there's quite a lot of recommendations around that as well, how to improve that. And then in terms of efficiency, ensuring and reining in costs, especially at the higher levels of the health system, you know, the recommendations around budget neutral payment mechanisms. We have DRGs at the higher level of the health system, but they are not bounded by budget neutral you know, approach, and therefore they are not helping to rein in costs as it was designed to do. So we made some suggestions around that as well. In terms of aligning the benefit package with the priorities, there was evidence from our benefit package subcommittee, very clear evidence that in fact most of the concerns for the population and even refunds from the scheme, about 70% of the refunds and so forth go to primary healthcare conditions, and those that could be actually managed by a lot of conditions that could be managed at the primary healthcare level. And yet, in fact, there was a perverse issue where many users were being directed more because of the incentives in the system towards the higher levels of the health system. So people were going to tertiary hospitals for primary healthcare conditions, and there was very little, control. No gatekeepers taking off any note. So actually, we, propose reinforcing the primary healthcare system and focusing the scheme mostly on primary healthcare, but this time not just for 40% of the population, but for 100% of the country. And given the fact that the scheme is essentially tax funded, it didn't seem fair that there was these funds were or taxes were being used to fund when they have to. So so made that those kinds of recommendations as well. And then looked at the wider health system issues and implications of the recommendations and the findings that we have. So, for instance, the question arose: what then is primary healthcare? Because it has never been truly defined in our context. What is primary healthcare? These are the primary care and the package that should be offered. There's quite a healthy debate about that, and we participated in that. The process actually has a process that was ongoing in the ministry itself to define primary healthcare. We actually, our benefit package subcommittee participated in that. That's to come to some conclusion that the ministry's role was to define what primary health care was for the country, but that the National Health Insurance Scheme would have to take its benefit package from there, not necessarily the same benefit package, as extensive as what the ministry defines, because the NHIS has to take account of budget constraints. And so we would, therefore insist that they look at the assurance say that they have to determine what elements of priorities in the PHC package can be afforded now, so that the PHC for all begins with an affordable package, but which can be extended in the course of time, given resources and further development and so forth in the context and so on. All of that. And then the coordination of service delivery, regulations, and purchasing mechanisms, as well, because there were some inconsistencies in some regulations. There were regulations that were hampering the operation of the health insurance scheme, and also, we were doing all of this in the context of donor transition, where some donors such as Global Fund and Gavi were transitioning out, and therefore putting further pressure in terms of the financing of the health system as a whole. And some of those pressures, in fact, actually, most of them are being borne by the National Insurance Scheme. So we thought that there was need for coordination there, rather than have that happen by default, but to have an actual transparent discussion about how those increasing responsibilities to be shared and what resources were going to be available to take them on going forward. So those kinds of recommendations, therefore, we made, and it became very clear that this was an effort that could not succeed without the involvement of all the actors in the system and with different rules and so forth. So that's really
great.
Because of in the time available, what we were able to accomplish.
That's great. Thanks a lot, Chris. And the technology works well, so I think we're happy that went pretty smoothly. Okay. Again, really interesting. Actually, just wanted to ask you, because you're a man with a particular position in Ghana and history and society as well. And I mean, if you do put a political hat on, I mean, how did the politics at the sort of party level and that sort of level and actually taking this concretely forward? Can you just give us a little, you're smiling there, give us a little snippet of reflections on that?
Yes, very much. I'm smiling because, you know, the politics has a big impact on the state of the report. Because, you know, we handed this report in September last year to the government. By December, there was an election, and the government was defeated in the election. So there's a new government in power, which, of course, was not the one that set up the review, and therefore their attitude towards the report is not the same. And that dynamic is currently what we are facing right now. There is actually a hopeful development in the sense that there is an principal agreement by the new minister to hold a small meeting, which was funded by USAID, in order to be able to look at the recommendations of the report and see what the new government might be able to take on or not take on. So that's the good news side. But yes, there was the political dimension was most apparent. We tried, nevertheless, you know, precisely because we knew that the election could have any outcome, and not only that, but also for the interest of the country, and because the scheme in any case was set up by a different party from the one that set up this review. We actually tried very much to be in our approach. So both in the committee membership and in the consultation, we consulted there was a purely bipartisan approach. I think the minister admitted that it was a very technical approach, which nevertheless was sensitive to the politics of the country. At least no one has made any major criticism of the work based upon the politics.
Followed, yeah. Okay, so watch this space, I guess. I don't think we have any Ghanaians in the room. We have some Ghanaian watchers, some close Ghanaian watchers. So I don't know if anyone has any quick questions for Chris. I know it's a little difficult in this. Agnes, yeah, go ahead.
Yeah, Chris, it's Agnes here. My question on the politics is, how would you see, is there any profound difference between the political parties in their position towards the NHIS? I mean, has there been some consistent differences, or is this basically an agenda that's been absorbed by all political parties, and are there different differences between platforms?
Yeah, no, thank you very much. And yes, I've been for a primer on Ghanaian politics here. I know. Yeah, actually, the broad answer is that there is a consensus by all the political parties about the scheme that they would like it to survive. You know, that is very clear, and that's the good side of it. However, we're finding that, in fact, the consensus there is within intra-party or intra-party differences are even more important. Because what we thought that because the current government was the one that set up the scheme and then lost power, you know, and the government that set up the review was different. In actual fact, the differences that appear between the current government and their initial iteration, the time they were in power the last time and set up the scheme, those two tendencies in that party are actually very different in their approach to the scheme. There is there are some signs that I'm not perhaps revealing any secrets, but there are signs that the current one doesn't have the same approach, in the sense, for instance, that it's being mooted all over the place, that there is no fiscal space for funding the national insurance scheme primarily to taxation, and that we must move towards premium-based scheme. This is not a secret because I've heard it said publicly. So, you know, given that and this is coming from the current government, but this was never mentioned by the previous one, which is a different political party. And this view is different from the view of the party when they were last in power. So I'm saying that the intra-party differences here, you know, seem to be more important even than the inter-party differences. I don't know if you are understanding me, yes.
No, it's very clear, thanks.
Yeah.
All right, Chris, thanks a lot. I think we need to draw that to a close now, but I think it'll be interesting to get more information as things develop further, and even the way things have progressed to date, if there's stuff written up on the process, I think that will be really useful. So thanks again, Chris, and I think you're going to stay on the line to listen to our last but not least speaker for this session. So just to welcome Dr. Ali Reza. Dr. Ali Reza is Director General for Health Tariff Standards and Health Technology Assessment in the Ministry of Health and Medical Education in Iran. I don't have that extensive a biography for you. I know you did your PhD in health policy at University of York, and you have a very strong focus on inequalities in health. But I think you, as we're getting your slides up, you're going to talk a little bit about well, you cover HTA, so you're going to talk a little bit about the HTA process in Iran, but also the recent political push in recent years with the current president. So thank you very much.
So can I have access to my slides from here?
So you just push forward and back.
Okay. Thank you, Matt. I would like to thank WHO colleagues, particularly Dr. Shaukat and Dr. Javed for bringing us together and for sharing the experience and for learning from each other. First of all, in this short presentation, I want to explain about the health transformation plan of Iran, which we conducted it in 2014. It has been started in that year, and now we are in the process that need to use tools such as strategic purchasing for moving that forward and for dealing with the challenges that we are facing with that at the moment. So the HTP plan was started 3 years ago, and the objectives of that was equity, access, and financial risk protection as the main goal. Some of the achievements that we have had during these few years are that we have been able to increase the coverage for almost 10% of the population, which didn't have coverage before that. And now almost 93% of the population are under the coverage of one of the health insurance organizations. And the big main achievement of this HTP plan was that we have been able to decrease the out-of-pocket of the patient from 53% to almost 40% in 2014. And I should explain that for near a decade, there was a problem with high out-of-pocket of the patient in the health system of Iran, and this is a great achievement for us. And also we have been able to improve the access for most of the areas of the countries, particularly in deprived areas, with helping of the government by adding the $3 billion added to the health system budget. This is the situation that now we have for the covered people. Let me explain about the main health insurance organizations which we have in Iran. The two big ones are in Iranian health insurance organizations and social security organizations, which they cover more than 85% of the population now. Before the HTP plan, it was about 75%, but now it's more than 85%, and they have been established, one of them more than 20 years ago, based on universal health insurance law in 1995, and the second one was established more than 40 years ago based on social security law. We have two two more small insurance organizations, which one of them is for armed forces, and another one is Imam Khomeini Foundation, which covers mainly the most deprived part of the population, which are the first and second quintile of the population. Some of the milestones in the insurance system of Iran, as I said, is the development of Universal Health Insurance Law in 1995, and again in 2007 we have been able to develop a unique health insurance benefit package for the first time that is used by all of the insurance organizations, and they are almost the same for all of them. And the last milestone is the HTP plan that we call it Rouhani Care, which is related to the government that we are at the moment. In terms of the benefit package, we have some health insurance benefit package that almost most of the necessary services are under the coverage of this package, but after the HTP we have added some other services in terms of costs or in terms of the service to that, and this part is covered by the Ministry of Health. I'm going to focus mainly on the challenges and the limitations that we have at the moment. We are a country in the middle income countries, and we are facing, of course, some limitations in the resources for covering even the current benefit package that we have. The challenge that we have, I think that there hasn't been a systematic approach to use of scientific evidence. Till now, we haven't used enough the power of the insurance organizations for cutting the prices, and also the decision makers don't consider fully the cultural, social, and economic aspects of the coverage. We have some, like many other countries, we have the problem of political and lobbying pressure on the benefit package designing, and also conflict of interest in the benefit package policies. I think we need a long-term view and forecasting, all of us, for the future, and we need to look at what is going to be happen for our population and the health of them. And so we are in a stage that we need to review and revise the HIBP at the moment. For the way forward, we think that in Iran we need to have this package, and we need to use the HTA and other evidences for revising that. A plan has been ready for revising that, which at the moment, from I think from 8 years ago, we have been able to conduct about 100 HTA in Iran. Almost 10 HTA every year. So the plan that we are going to conduct is based on dividing the current list to white, black and gray lists, using the evidence such as HTA. We have a new burden of disease study as well in our hand, and we're going to use the experience and the view of the stakeholders, of the different stakeholders for revising that. We're sharing this experience with some other countries as well. For the short mechanisms that we are going to do that, removing OTC, over-the-counter medicine, from the list of our covered drugs, and also developing some guidelines which we are facing the problem of implementation for those. As the last slide, I think that it is not easy to use a single strategy for strategic purchasing, and so we have to look at different aspects of our resources that we are using in our insurance system. We need to have a powerful health insurance system by merging them if possible, and if not, by bringing them together and having an integrated health insurance system. And also, I think in Iran we have the problem of having evidence, but it is not compulsory to use them. So we need to revise the law based on the current situation. And also we are going to use the power of the health insurance organizations for bargaining with the companies of medicines and equipment. There is a plan, and there is a discussion with Australian government to change the payment system of hospitals, insurance organizations to hospitals, to DRG, and also we're going to make some limitations on outpatient expenditures for the coverage of the population. Again, thank you for your attention and for thank you.
Thanks, Alireza. That's great. That's really interesting. I don't know if colleagues from the Iranian, if you'd like, no, Dr. Harichi, okay. If you want to add anything, please let me know. But Jack, would you like to please come in? Thanks.
Jack Langenbrunner, Gates Foundation. First of all, congratulations for the progress that you've made in Iran. Not having been able to work there for 7 or 8 years, I'm very impressed with all of the things that you've either addressed in terms of insurance mergers or benefit packages, and also your strategic thinking for the way ahead. So it's very impressive. One thing I didn't hear much about here was the issue of primary care. So you're known globally for your rural primary care system. It's one of the best in the world. We've sent delegations from many different countries to Iran to look at the rural primary care system, and I'm wondering what you're doing maybe in the urban areas that tie in with some of these reforms that you're thinking about.
Would you like to respond now? Yeah, go ahead.
Thank you for your interesting question. It wasn't enough time to explain about PHC. Part of the HTP plan was expanding PHC from rural areas to the suburb areas, and the next plan is to expand it to the urban areas of Iran. So, and also we have studied about piloting the family physicians and referral systems from rural areas and expanding that to the urban areas as well. 10 provinces of Iran at the moment are ready, out of 30 provinces, are ready to implement the referral system connected to the family physician. Now, I think if this government continue after the election, one of the main plan of the empowering the PHC would be implementation of the family physicians and referral system in those areas.
Yeah, Dr. Harichi, please. Yeah.
30 years ago, about 70% of our population lives in rural areas. At the moment, the vice versa. 75% lives in urban areas with more expectation and needs. And we planned a coverage, maybe you know Behbars, our well-known nouns. We prepare for rural areas, especially in the deprived areas of urban areas and small cities in the first step, cities with population less than 20,000 and 15,000 and at the moment 100,000, and then to big cities. All of our population have a Behbars in rural areas or health experts with Bachelor of Science and with special education for multipotential work. And at the moment, each 2,000 to 3,000 of people have an health expert. And they have electronic recordation. About 65 million of our people, about 84% of our people have this record and referral system, and we hope to do in whole of the country like our rural areas. Thank you.
Thank you, Dr. Harichi. I think we have a little bit more time. If they have one comment at the front. I can't. If you put your cards up, it's not so easy for me to see me. So stick your hand up in the air if you'd like to speak also. But please, yeah.
Yeah, I just have a very small question regarding the plan as such. What can you say about the strategies or the lessons that we can learn from your plan by putting aside the advantages given by the economic growth and fiscal space of the country? This is maybe a difficult question, but just to know about the lessons that we can learn from this experience. My second question is about the role of university hospitals as structure. Iran health system is particularly different from ours by the role of the university hospitals as the head of the health pyramids of the health provision in the health system. My question is, what is the role of these university hospitals in enforcing the use of guidelines in health institutions? So that's
thank you for your question. In Iran, we have about more than 900 hospitals, which more than 60% of them are university hospitals, and more than 80% of the inpatient services are provided by them, and the remaining 20% are provided by private sector and others. So in terms of guidelines that you mentioned, you mean the clinical practice guideline? Yes. We recently, it is a decade that we are developing guidelines, but there hasn't been enough opportunity or good opportunities to implement them, because implementation is very difficult, particularly when you don't have enough infrastructure for that, including the softwares and also the resistance by the practitioners and clinicians. So recently, during the HGP plan, His Excellency, our Minister of Health, announced about 100 clinical practice guidelines that have been adopted during the few years few recent years. So at the moment we are in the implementation plan. For the first questions that you mentioned, which kind of considerations that we have in terms of maybe economic crisis that we are facing for that and this fiscal space. I think that we have passed some kind of crisis in our economy, and we think that during the next few years we won't have some, big crisis in our economy. So, but we have to think that even though we won't have more than now resources that we have at the moment. We are planning with the resources that we have in our hand at the moment, but we are not going to expand the health system market more than that we have.
Yes, thank you for your questions. We do more economic growth in health system in the field of sanctions and down pricing of the oil, one of our main things. The major point is the political will by president. He was the only person that promised to people universal health coverage and coverage of insurance by all people. We trade off by him and some other persons in election to do something for health, and people bring their nomination for you. The second point is stewardship. We think the stewardship in our health system by the Ministry of Health in recent years after HTTP has increased largely. And we do more for paying money for good performance. For example, we construct a system that public sector, including our insurance company, purchase the same service with less expense than from the private sector. And one of the most important things that in our country that we do with stewardship and with the governance, we declining significantly, about 98% of under table. It includes about 10 to 15% of our total health expenditure, a huge amount of money. But at the moment, it is there isn't any under table or illegal payment in public sector, and in the private sector is declined to about 90 to 95%. Thank you.
Great. Well, are there any more questions on any of the presentations this morning? It's been a long morning. So if not, then we'll bring it to a close. Just a few quick comments. I think there's clearly a lot to learn, I think, from certain countries about getting a sound participatory process in place, even a sound technical process with the necessary information for that to happen. But even once we have all those, and even once translated into policy, actually turning those into effective coverage on the ground for real change in health system performance is, of course, another matter, and that's the main focus of the remainder of this meeting. The way benefits are defined, I think, or articulated, can be important for health systems to make progress on objectives, particularly transparency, to translate legal entitlements into language that beneficiaries understand and can be enforced, and which purchasers can actually operationalize. And just one other quick reflection that we often talk about is the difference between being explicit and being detailed. That there are times, particularly at the primary level, we often come to this point that one can be overly detailed. And that can actually have confusing can be confusing and can have negative implications for access. So I think we'll stop there, and obviously the connection between benefits and purchasing in particular is the main focus. There are many other elements, service delivery capacity. I mean, Wallapon, you brought that up as a particular. It's not the main focus of this meeting. So unless there's any further comments, I think we'll draw to a close there. Joe, did you want to say something? No? Okay. So, yeah. I'm just looking to see if there's any final comments. I don't see any hands, so. Okay, yeah, Inka, thanks.
Well, thanks so much. I have 3 short announcements. The first one was a couple of participants asked whether presentations will be available, and yes, indeed, they are on the Dropbox. We had shared the link a couple of days ago, so this is where you will find the presentation. Now, as we have translation, we have to, try to really stick to the schedule because they're working along that schedule. So the idea is to come back at 1:45, so in an hour and 10 minutes. And maybe the most important thing is now about what we purchase for the lunch package, because the whole meeting is about purchasing, and we had very serious purchasing questions here as well. So what should be in there? What kind of quality? What is it that we want to give you? So it's all about values, preferences. We had long discussions: warm meal against not a warm meal. What's feasible? And in fact, the feasibility question is the service delivery of that lunch is the big challenge. We have upstairs the WHO cafeteria. However, there's a long queue, and we were trying actually to get a fast track, a preferential treatment for you. But still, even with that, there would have been a long queue with all, with the number that we have here. So in fact, because of that, we have now sandwiches outside there, just in front of the room, and I hope that's also meeting to some extent your preferences and priorities. It's not a warm meal in that sense, but I hope you enjoy, and then in 1:45. Thanks very much.
And I'll just announce that once again, thanks to the speakers, many thanks to the speakers for their contributions, and for the WebEx participants, I think at 1:45 we'll be back with the next session. Thank you.